Thank you again. Appreciate the opportunity to be here. I'm Bo Ryle, President and CEO of the Arkansas Hospital Association. Our association represents 100 hospitals across the state of Arkansas. So let me just start by answering the first question that we all are thinking. What is the Hospital Association's position on moving to a DRG payment system? So I guess I'll start with it. The goal of the DRG system is to move to a payment system that is tied to a diagnosis, but is also tied to a reasonable payment for the services provided. Then we think that is a reasonable discussion to have, but not such an easy task. As you saw earlier, hospital finance is very complicated, and there is a great deal of work that goes into the development of a Medicare DRG. So we don't want to underestimate how much work is going to go into developing a Medicaid DRG. It's going to take some time. It's going to take a lot of work. If the goal of the DRG payment system is merely to reduce hospital payments, it's hard for us to see how low hospital payments can go for Medicaid as opposed to what they are currently. I provided you with a study that BKD accounting firm did for the Arkansas Hospital Association, which looked at cost reports for 44 Arkansas hospitals. It excluded UAMS, Children's Hospital, and the critical access hospitals. So for those 44 acute care hospitals, Medicaid paid 52% of cost for inpatient services and 33% of cost for outpatient services. And we're talking costs, not charges. The Medicaid inpatient rate currently is $850 per day. Per day, and that does not differentiate if it's a broken arm, if it's heart failure with the replacement of a pacemaker. It is the same $850 per day. The Medicaid outpatient fee schedule has not changed since 1992, and that was a decrease in payments on hospital outpatient. Hospital inpatient has not changed since 2006. On those payment rates to those 44 hospitals, they lost $265 million serving Medicaid patients in 2013. This number had begun to get so high over the years. That is why the Hospital Association and member hospitals chose to pursue a hospital Medicaid provider assessment. That assessment has allowed for a $157 million reduction in those losses, which arrive at now currently $109 million that those 44 hospitals lose by serving Medicaid patients. By inserting the hospital Medicaid payment assessment, that gets us up to 78% of cost of providing Medicaid. So as you can see by those low payments, hospitals are currently a significant value to the Medicaid program. We're providing below-cost care for the services that are provided. So we wonder if the goal is to reduce those hospital payments. It's certainly a concern, considering that the private option, on the other hand, was therefore a savior for those hospitals. As far as critical access hospitals, they are the smallest of the smallest hospitals. If you know of those, they're in the smallest towns across the state of Arkansas. Critical access hospital is a federal designation that only allows for a hospital to have 25 beds or less, and a patient cannot stay for more than 4 days. We have 29 critical access hospitals across our state. Those hospitals are paid at 99% of their allowable Medicare cost and 100% of their allowable Medicaid cost. These payment rates allow these hospitals to stay open and provide access to rural communities. These hospitals do not have much of a margin, if at all, and most lose money. So it's caution you as you move to changing the payment system for a critical access hospital. If it goes much lower, this certainly will result in closure of these hospitals. I've got with me Paul Cunningham, who is our hospital finance specialist, and I'm going to turn it over to Paul right now to make a few comments.